Thank you, Dan, very much. I appreciate that kind introduction. I'm actually very honored to be speaking today and grateful that you're letting me speak remotely. I find travel really stressful. So when I was first approached about this symposium on violence and mental health disorders, I thought to myself, well, that's not really something I have any experience of. And then Bob reminded me about restraints, and I think that's squarely within what we're talking about, and I'll say something about that in a minute. So again, I have had violent fantasies and fears and so on, but fortunately I've never either directly threatened anyone, I had made indirect threats, nor actually hurt anybody. And I feel incredibly grateful and lucky that that's the case. And why is it? And I think of two possible reasons. And one is that demographically, I'm not like the right person to do that, coming from a stable home with resources and love and no violence and that kind of thing. And second, I think there's always been a part of me that maintained some kind of empathic connection with the person I was also frightened of. And that served as a kind of restraining influence. In any case, I'm very grateful that my analysts were willing to sit with a certain amount of anxiety about my violence potential to spare me hospitalization, which I found very traumatic. As I've come to in another connection, I'm pro-psychiatry, but I'm very anti-force. So I'd like to talk a little bit about mechanical restraints. The topic is relevant to a discussion on mental health violence because the act of restraining is, even well-meaning, an act of violence, and it's supposed to be in response to a perception of patient violence. And I want to focus on 4- and 6-point restraints versus, say, helmets for a headbanger. Such restraints, if used for any length of time, are extremely painful. It's hard to overstate that. Very degrading, cause feelings of profound helplessness, and are utterly traumatic, especially for trauma survivors, which I'm fortunately not. So I was in restraints close to 24 hours a day for 2 days, and then for the next 3 weeks I was in restraints anywhere between 4 and 15 hours a day. And then I was transferred to another hospital, and even though my behavior didn't change, I stopped being restrained. And it's actually a robust finding in the literature that whether you're restrained has more to do with the ward ethos or the hospital ethos than it has to do with patient characteristics or patient-staff ratio and so forth. Anyway, being restrained was the worst thing anyone ever did to me. I had nightmares for years. I used to wonder maybe I was a wimp, but then I met an Afghanistan vet, a vet from the war in Afghanistan, who was restrained and described it as one of the painful and traumatic experiences in his life. His book is called An American Resurrection and describes this experience. It sort of normalized for me my toxic response to restraints. Why are they used in the first place? When I first looked at this issue as a law student, where I had had my breakdown my first year at Yale, there were a lot of people in the literature saying restraints were a form of treatment. They help people feel safer. I've never heard a patient express anything like that, and I've certainly heard a lot of people express painful feelings about it. Also, studies ranking emergency modalities among patients, restraints don't always come last. The second use of restraints is arguably more justified, legitimate, to protect patients and others from patient violence. Here are a number of things said. First, even with good statutes, restraints are abused. So in Connecticut, at the time, the statute said that you could only be restrained if you were imminently dangerous to self or others. At the law school, we had a mental health law project that worked at Connecticut Valley Hospital, and we had a client whose chart said over and over, patient restrained for refusing to get out of bed. Doesn't sound like imminent violence, sounds more like discipline. Second, it's very hard to predict danger, and doctors often get it wrong. I don't think I was ever seriously dangerous, although I was agitated at times. And at least one study has shown that patient perception of their own dangerousness varies widely from what the doctors think in the restraint context. Third, the restraints process, again, even if well-meaning, is itself an act of violence and can be more dangerous than leaving the patient be. My understanding is that most staff injuries happen during the restraint process. That means either staff is really, really good at predicting violence, or it means that restraints cause people to be more violent. Fourth, there are less restrictive alternatives to restraints usually, like staff specialing someone or putting someone in a padded cell, which I think is much preferable to restraints. Finally, there's evidence that restraints may cause more deaths than they actually save. There was a series of articles in the Hartford Courant about restraint deaths, and a Harvard statistician estimated that each week in this country, 1 to 3 people die in restraints. They aspirate their vomit, they strangle, they have heart attacks. Given alternatives, ways to protect people, it's not clear to me whether restraining people is costing lives or saving lives. So in light of all these problems, it seems that we should be aiming to reduce the use of restraints, and there's some gratifying evidence here. Restraint reduction efforts work. For instance, without increased costs or violence. Philadelphia and Massachusetts at the child level, adolescent level, have greatly reduced restraints. And indeed, England, where I was living and a patient, has largely done without the more extreme forms of restraints for more than 200 years. If it can be done, it should be done. So in light of all this, if I were a restraint czar, what would my law look like? First, I would greatly limit the occasions on which restraints could be used. For example, if someone is extremely violent during transit and it might impair the driver's ability to be safe, or where a doctor or a nurse needs to be with a patient at close quarters to evaluate or talk to him or her, and there may be others. Those are just the two that seem most prominent to me. In addition, and even if we stay with the danger to self or others standard, I would do other things. For instance, I would procedurally burden the use of restraints more than they are now. You know, doc has to check every 15 minutes, every hour you have to try to let the person out of restraints. New York has a pretty good law, and surprise, surprise, the epidemiological evidence is restraints get discontinued at the point where a new intervention has to be done, you know, doctor seeing the patient or whatever. Third, I would change the liability regime. Right now, if you fail to restrain someone and there's injury, you can be liable. Conversely, if you restrain someone and you shouldn't, it's only, unless the person has physical injury, it's only dignitary harm and very little recovery. And I would change those incentives. I would say that if you don't restrain someone and violence happens, you're liable only if you were grossly negligent in not restraining someone. And conversely, if you restrain someone and they have dignitary and psychological damage, you should be subject to a lot of recovery. Next, and this is a very simple point, but I think it's important, I would make it a requirement that patients be informed on being restrained what they have to do to get out. For instance, you say to the patient, if you don't call out, scream, or struggle for 15 minutes, we'll let you out of restraints. Part of the trauma of restraints is your utter helplessness. You don't know what to do, you don't know when you're going to get out, what's going to happen. Giving patients this information should reduce their feelings of helplessness and increase their sense of agency, restore some agency to them. Next, I would videotape all restraints episodes as a check to see that staff is using restraints appropriately. Patients after the fact may want the videos erased, but I think that they should be done as a default. And finally, I would absolutely forbid spread eagle restraining. While not abuse victim myself, there's considerable evidence that abuse victims are extra traumatized by these kinds of restraints. Restrain someone to a chair, put mitts or a helmet on them, or tie their wrist to a stationary object, but don't spread eagle restrain them. Anyway, those are just some of my thoughts about violence in the context of restraints, and thank you for inviting me to speak.